I do breast cancer care and breast cancer research. I use mice. I give them your tumors so that they can grow your tumors, and then I can test therapies on them. And look for things that are circulating in their blood that will let me detect cancer earlier and give me an idea of whether a therapy that we're trying is going to work. So I work with a whole bunch of other investigators at the University of Florida, and what they each do is they study a certain pathway that has been discovered to be active in breast cancer, and they've developed inhibitors of that pathway, and then we bring them to, after we've shown that it kills cancer cells in a dish, it's not a terribly high bar to get, and it kills the cancer cells that grow in a dish in a mouse, then we try actually human tumors that are growing in mice, and we see if that's any better than standard care. Okay, so that's what I do to try and push this stuff forward. It's still not perfect. A mouse is not a human, but some of these drugs have considerable toxicity, and I would say we're only hitting at about 20% of those pathway inhibitors actually seeming to do much in the mice. But I would rather test them in the mice rather than testing them on all of you, right? So, the good news is that slowly and steadily we are making progress against breast cancer. I think you all recognize this. The average woman diagnosed with breast cancer in the U.S. has a 90% chance of being alive and well at 10 years. However, with the metastatic or even just the recurrent setting, so recurrent to me is a little different than metastatic. Recurrent can be just locally recurrent, which is between 10 and 30% of people who come back with a recurrence of their disease. This is just regrown in and around the area where it was originally. And those we can re-cut out, re-chemo, and often we'll get a cure. On the other hand, the other 70 to 90% have spread to other parts of their body. In 1970, if you had a recurrence, your 5-year survival was 10%. And slowly we made progress. The 80s, it moved all the way up to 15%. Woo. The 90s, we got up to 25%. And by the 2000s, 2010s, the 5-year survival for all recurrent disease was about 44%. But for metastatic disease, it's still a little shy of that. Okay, so when I see a patient with metastatic disease, they're asking me how long, and I'm telling them that we'll have to see, because I can't de novo predict how they're going to do. I'm not God. He hasn't given me the prophecy power, but that I have patients all along the spectrum. I have one metastatic patient who got started on tamoxifen 23 years ago, still has visible disease, but it is still under control with tamoxifen 23 years later. That's fantastic. She asked me if she could try one of these immunotherapies that she's seen advertised. I said, no. We are not going to rock this boat. But everybody with metastatic breast cancer, we have a frank conversation, because this is a terrorist organization, right? That's what metastatic cancer is. It started with an individual who, through environmental exposures or inherited mutation, became a little off, and then continued to grow in that offness, right? And to acquire more alterations through their exposures, and to divide and propagate those changes. And if we find those early, you can quash a newborn terrorist cell if you find it, right? Eradicate it. But once it has grown to a certain point, it starts sending offshoots all around. becomes a lot more difficult to control. Okay? As they're finding out, as we're finding out, all over the world, right? So, we've made great strides in improving survival, but we still haven't found the magical cure. We're getting closer and closer. And we're getting more refined in the ways that we're approaching cancer. In 1970, there were 5 drugs. They were all very harsh chemo. Think of it as napalming, right? So napalm works, it eradicates cells, but it tends not to be great for the surrounding population, right? But the good news is now we're up to about 40 drugs approved for breast cancer. And over the last 5 years, there have been 13 new drugs. Over the last 2 or 3 years, there have been 9 new approved drugs. All those are targeted therapies, which means they predominantly hit just the terrorist cell and avoid damage to the surrounding structures. We've also progressed in finding out what the alteration was that started this whole process to begin with. In the last year, there was approval of something called a Foundation 1 test for tumor testing. And this looks at a little over 300 genetic mutations or genetic alterations in the tumor, and helps us figure out what the thing that started this or the thing that's continuing to push things along. Sometimes what starts it loses its relevance, and you gain new changes that really accelerate how the tumor grows. So this has led in the last year to the approval of 2 drugs where we target the mutation rather than the generic process of rapid cell division. One of those is a drug called olaparib. It was just approved this year, 2018. This is a unique drug because it was approved for women who carry BRCA1 or 2 mutations. Not the tumor's mutations, their mutations, but that gets propagated in the tumor, and that's what helps start the process of making cancer. So in women who have one of these mutations, this has a pretty significant prolongation of progression of disease or recurrence of disease. Also in the last year was a drug that was the first drug approved that targets a mutation independent of cancer type. We typically live in silos of, for breast cancer we use this, for lung cancer we use this. Well, in the immunotherapy world, what we've come to recognize is that activating the immune system can be effective against most cancers. Breast cancer a little less than most. But if you have certain mutations, in this case, a macrosatellite instability, it's a certain kind of DNA repair pathway. If you have a mutation in that ability to repair, you are more likely to respond to this drug. So now, if we find that you have this mutation, doesn't matter if it's prostate cancer, lung cancer, breast cancer, colon cancer, then we can use that drug. It's far less toxic, although if you have toxicity, it can be pretty bad. But this explosion of new drugs does have new burdens. More targeted therapies, more boots on the ground cost more money, right? We have our standard chemos, and they'll run you anywhere from 10 to 20,000 for a set of treatments. But now we're looking at regimens like TCHP in HER2 positive breast cancer, and you're looking at 280,000 a year. Okay? So we have a ways to go to figure out how to pay for some of this. So when I see a patient with breast cancer of any type, even metastatic or early, I describe the breast cancer as this ISIS, and our goal is to keep things under control. In the metastatic setting, control is the issue. And I don't want to napalm everything because I don't want to kill them in the process of killing their cancer. My goal is to hit the hot spots, keep things under control, because right now I don't have the armamentarium to target every single one of their cells. Because every patient is different, every patient has goals that are different, but every tumor is also different, and even more complex is every cell within that tumor is different. Because they've each acquired their own mutation, which also helps make them resistant to the napalm. So, there are a few settings where I do at least talk about cure in the metastatic setting. That's in the oligometastatic setting. You've got one or maybe five, maybe up to 5 spots of disease, small spots. But I always have to frame this, and I use the reference of a raffle ticket. Okay, so you buy a raffle ticket, your odds are not terribly good, but you buy it because it's for charity, and who knows, you might win that, that car, that lease, that birthday cake, I don't know. If I use combination chemotherapy, sort of broad spectrum chemotherapy for a metastatic patient, I've got about a 10% chance that I'll make all their visible disease disappear. And that's pretty good. But it's going through my harshest, biggest gun. It's going to cause a lot of collateral damage. Now, of that 10%, roughly 10%, 10 years later won't have had a sign of recurrence. So, quick math, 10% of 10% is 1%. Okay? So this is where it comes to discussion. Do you want to buy the raffle ticket, knowing how much that's going to cost? How much collateral damage is that going to cost? Or do you want to conserve your resources, not just money, time, wear and tear, effect on quality of life, because high-dose chemo is not easy. And then I discussed that each breast cancer is different. We segregate breast cancers somewhat crudely by what they express. In the 1960s, we discovered the estrogen receptor. We started staining, and we could show that people who were estrogen receptor positive, generally, it took longer for them to recur, and it generally took longer for them to progress. And if we did things like take out their ovaries, and then later gave them tamoxifen, and then later knocked out production of estrogen with aromatase inhibitors, and now do things like giving them pills that block the resistance pathway that first develops. We can prolong the amount of time that they essentially look and act fairly normally, although very menopausally, to first therapy now. Median time on first therapy is approaching 2 years in the metastatic setting, which used to be median survival, not median time to first change of therapy. And that's happened gradually. That's where we are now. Whereas if you're HER2 positive, the protein for HER2 was discovered in the 90s. And at that point, HER2 was a death knell. They were the most aggressive, came back very rapidly, progressed very quickly. That was the worst. So you hit them the hardest with the napalm of the time. Now, we have agents that target HER2. So HER2 positive disease actually has every bit as good a prognosis as the estrogen receptor positive disease in the metastatic setting. In the adjuvant setting, it's similar. We have a lot of targeted therapies, a lot of therapies that actually have fairly minimal toxicity. But we still have the bugaboo, and that's the triple negative group. They don't overexpress the estrogen receptor. They don't overexpress the HER2 protein. And we're still trying to figure them out. We're doing genetic screens, we're doing genetic sequencing, and it turns out that those are separating into subtypes. And some of those subtypes are targetable. So there are many drugs in the pipeline right now that target those subtypes. The most promising to me is something that's called androgen receptor positive. It turns out that almost as many women as have ER positive disease have androgen receptor positive disease. So androgen receptor is testosterone receptor. And so now we're probably going to start using some prostate drugs for breast cancer. And the side effects are similar to the estrogen blockers. You're going to get more menopausal symptoms. But it's a lot less benign, or a lot more benign than throwing napalm at you. And hopefully we can continue to shift that bar. Also, in the triple negatives, we are noticing that there's a much higher mutation load, which means that they're more likely to respond to these immunotherapies. So immunotherapies still aren't there in breast cancer. They're coming down the pike. They're still not quite there, unless you're one of these MSI high. The MSI high just means that you can't repair your DNA very well. Okay? The BRCA1 and 2 mutations, if we target the ability to repair, then we could, and that's what the olaparib drug does. Or if we target that now that you can't repair your DNA, you're going to make more abnormal proteins. More abnormal proteins means that that might be something that your immune system can see as different. Because we want our immune system to find the different, right? And we don't want it to find the stuff that's the same, because that's called autoimmune disease, lupus, etc. So in generic metastatic breast cancer, immune therapy response rate is 10 to 20%. That's the same as I can get with any chemo drug. But in certain subsets, that seems to be going higher. So if we can figure out which subset is best to be targeted, that would be great. Downside again, most of these immunotherapies are, how much are immunotherapies?
$20,000 a month.
So not cheap, not entirely benign. They can cause an autoimmune disease. But the good thing, the promise in the immunotherapies is of that 10 to 20% that responds, about half of those seem to have a really durable response, meaning several years. And a few of those, we haven't seen a recurrence yet. So we might be pushing that raffle ticket, the odds on that raffle ticket up some. Does that make sense? So, what we're trying to do is to continue to push that. I offer patients, here's the spectrum of what we can do. I don't know all of your circumstances. I don't know how much family support you have. If you don't have a lot of family support, a lot of support at home, that makes getting through therapy all the more difficult. If you don't have a lot of family support at home, or support of some sort at home, the simple acts of just getting to your appointments, tolerating sitting through your infusions, someone who will be in the background telling me when I ask, are you feeling okay? Any nausea with this? I'm fine. And they'll be back there saying, you do need someone to tell on you sometimes. And I know that there are many supporters here as well as patients. and I extol every one of you. I fortunately haven't had to be in your shoes. So, by definition, I can't know what that's like. But every day, I'm reassured because of the perspective of people with metastatic disease. It really refocuses, really refines what is important in life. You teach us every time that we see you. So give us your feedback, and we will continue to try and push and push the therapy where it needs to be.